Hey everybody, it's Andy Haig. This is the second week lecture for the Africa Rehab Fellowship. And my real focus here is trying to change your habits so you do a better job. I'm in my office. Well, not really. In Vermont, they say we have 11 months of snow and 1 month of damn poor sledding. The sledding's not so good today, so I'm out at the cottage. And all of us Vermonters do this in August to September because it's so beautiful. There's a lake down there. And we all do our work from home. So for instance, the guy next door there, he's doing a craniotomy in the back room. So if you hear any screaming, it's the anesthesiologist was out fishing. That's just how it works here. So how am I going to teach this to you? I'm going to model an interview with a patient. And I'll throw you the punchlines as we go here and interrupt a little bit. But I think the most important thing ever is for you to understand how you're going to talk to the patient. So we'll give that a swing, and I'll stop here and there. Hey, Mr. Smith, where are you from? Oh, Chicago. I see. Where'd you grow up? Oh, you grew up in Southern Indiana. I see. I see. And what do you like to do for fun? No. Before you got hurt, what did you used to like to do for fun? Oh, you were the world's top ranking bowling guy. I see. That's different from what I thought, isn't it? First, you must get the patient to own up to being in the room with you and interacting, and you must respect who they are as a person. This isn't just soft stuff. All the predictors of back pain disability have to do with those factors, and you start out that way. You don't later on say, oh, by the way, right? Okay, so that's how you start out. Well, so Mr. Jones, you know, you've had pain for many months. You've seen a lot of experts, and you come to me and, you know, when we're done, you're going to buy something. You know, like all I do is give you stuff to decide to buy. And it's important before I know what's wrong for you to understand what it is a doctor does. I got these things. I got surgery, injections, pills. Yeah, I know you hate pills. It's okay. But I do have pills, and I'm going to talk about them so that you know what you're missing or not missing. I've got all kinds of therapies, PT, chiropractic, et cetera, and I've got rehab. Rehab. Oh, so look, when somebody has their leg cut off, I'm really busy. I'm a rehab doctor. I didn't put their leg back on. I don't cure them. So for back pain, sometimes rehab is important, even if we're not curing you. So I want you to think before you and I really get going, what is it you would let me do? What is it is worth doing among those things? And we'll come back to that at the end of the visit. Okay. So I want you to tell me what you're feeling these days. No, not how it started. We'll get to that later. No, I don't want to know that you're feeling your piriformis because I'm not sure you know what a piriformis is. Just give me the symptoms that you're feeling these days. Where do you hurt? Can you point with one finger? Yeah. And what could you do here in the room that would make it worse? Show me something that makes it hurt. And outside of the room during your daily life, how does this affect you? Could you walk as far as you wanted to? Could you have to lift? What about work? How does this affect your lifestyle? Well, of course, then, gang, I'll go into the regular medical history and physical, but not until I really understand the current symptoms, okay? The most dangerous thing is for you to presume that the people who sent the patient were right, or that the patient is right. Just get the facts about how things are now. Things like herniated discs get better, and the residual is sacroiliac joint pain because they walked funny, and it looks like a herniated disc, but it's not, right? So just listen to the symptoms you have now. So you're going to do your history. We'll go into that in my slideshow. You're going to do a physical examination. And there are some touch points on the physical examination that I want you to understand. And for that, I'm going to pull up a couple of the slides that are in the slideshow that I'll send along with you soon. Here's our slideshow, and we'll skip forward on a few things. Here's my fingers. Make sure that you get to know what's wrong. Ignore imaging, I guess was the other point here. You can look at imaging after you've drawn your conclusion, okay? And then on the history and physical, the onset, diagnostics have been done, treatment, and functional consequences. This is pretty basic stuff. I'm just scooting through it with you, right? All the other stuff you know from being a medical student. But think about the functional review of systems. That 87-year-old woman might be selling real estate still. That 55-year-old man might be taking care of his daughter with a disability and have to lift her up, right? So you need to understand where it affects their life. Then after you get the history and physical, I want you to answer these questions. If you were a resident or a fellow or even a medical student in my clinic, you'd come out and you'd want to spout off the stuff like you do to every attending, chief complaint, history of present illness, and I'll stop you right away. And I'll say, don't tell me a word. I got to tell you something. They died. You missed it. What did you miss? Now, the medical student answer is cancer, infection, fracture, Cotta-Quanta syndrome, blah, 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 blah. And that works great to get yourself out of trouble with your attending doctor, okay? But when you grow up and become a big kid, you're going to fall asleep at the switch on back pain. The research tells us this is true. Disc space infections, all the information that the person has one is present for weeks and weeks and weeks before a doctor thinks of it. Okay, the diabetic running a fever with back pain and the doctor doesn't click. So the game you want to play for the rest of your life is to pretend in every case that there's one thing that killed them or that caused profound disability. And that makes you narrow it down. This is a 25-year-old woman with low back pain of 4 weeks duration. It's nothing. And then you miss it, right? Well, it's a 25-year-old woman with 4 weeks of back pain. Well, the thing that kills 25-year-old women is cervical cancer. Oh, I guess not. Okay, the minute you blow off the most likely cause of danger, number 2 and 3 and 4, they'll come naturally. So every case for the rest of my life and your life, we're going to say, what's the one thing that I can narrow this down to? It causes you to think and focus, okay? Next question. Yeah, rare for the killer to be the second choice. What's my bottom line diagnosis? Now, this is critical because when you start looking at diagnostic tests like MRIs and X-rays and CAT scans, you can't come in there thinking the test is going to give you an answer. You know, I've harped on it before. MRIs have false positives, X-rays have false positives, false negatives, et cetera, et cetera, et cetera. So before you go further, if you were staffing the case with me, you'd say, I'm not so sure, but my best guess is that this is the left sacroiliac joint. When the MRI shows disc herniation, it still could be the SI joint because your clinical guess is better than a picture, okay? So the next question you want to answer is, what is the diagnosis based on the history and physical examination? You got to stake a claim before you look at test results. You think to yourself, how could I prove myself right? Well, sacroiliac joint, I'd have to do an injection. It's not worth it right now, but at least I know what I would have to do. And then you want to know the psychology of the person. And all of you have had a lot of psychiatry background, but I like to dumb it down even stupider, which is like this. Ask, are they dumb or smart? Are they happy or sad? Are they talking back and forth with the butterflies? And would you have fun with them if you met them at a party? In other words, what's their cognitive ability? What's their mood? Do they have any thought disorders and what their thought processes are? And what are their personality traits and possible personality disorders? Okay. It's not adequate for a physiatrist to say, this dude's crazy, I'm not going to operate. That's what a surgeon can do because all they got is one trick, okay? A physiatrist has to say, wow, she's got a personality disorder because of abuse as a child, and right now her sleep is so disrupted that I think she's also got major depression. And I'm going to what? I'm going to understand how that abuse as a child affects her pain, and I might prescribe a medication for the major depression. My job is to look at the whole patient, and so I need to get very psychiatric in understanding a patient when they come in. Remember, these are the predictors of disease and disability, not the physical exam, okay? And then finally, you got to think, what is their functional need? I went through an inpatient unit one time, 40 patients, and of 40 patients, there were only 3 where somebody actually said something about the person's job. The classic thing on a medical doctor's note is social history, doesn't smoke. You need to understand what the person does for work. If you don't understand what a iron worker does compared to a steel worker, you have to ask them because they're an expert on that, okay? And it has consequences. What are the functional needs at home? And by the way, we don't live to work, we live to have fun. There's somebody out fishing out there right now, and they're glad they work because they could buy a fishing boat, okay? So avocational stuff is the biggest motivator, okay? So let's go to the examination. You elsewhere, I've got the physical examination, but there, and I'm going to step out of my slides here because I don't want you to look at slides. I want you to think with me, okay? You're thinking pain generators. If you can't make it hurt on your exam, worry, because if you can't make it hurt, it might be something deep or they might be a little bit crazy, okay? In other words, aortic aneurysms don't hurt when you push on the sacroiliac joint, okay? And people with mental health problems that interfere with their pain reporting will give you irrational pain behaviors. The irrational pain behavior is something that, again, we need to be very respectful of mental health problems and also understand that there are secondary gain issues that make people give us bogus or fake examination findings. Gordy Waddell passed away a number of years ago, and Gordy was a really great humanist and a surgeon, and he got sick of us all just saying, she's crazy, he's faking, call the police, right? He said, let's quantify this and understand it. So there are 5 signs called the Waddell signs, named after Gordy. And anybody who has 3 or more of them is in no way a surgical candidate unless there's a medical emergency, okay? And the 5 signs are the pain behavior when they come in the room and when you examine them. If they're grunting and groaning and screaming and bumping and lumping, you score 1 point there, okay? The second one is pain on superficial palpation. So when I'm examining the back, I'll run my fingers down their back, and I'm only deforming the skin, if anything, just to see where the anatomy is, frankly. But also, if they go, oh, and they're hurting, and all I did is deform the skin, that's not quite real, okay? The third is pain on fake compression of the spine. And that's done 2 ways. If you have somebody sitting like me and you push on their head and they say their low back hurts, that just doesn't happen. That's not physiologically possible. Their neck takes it in, okay? The other way is to grab their hips and their arms, make them rotate the whole trunk en masse, okay? And if they hurt, either they got hip arthritis or they're faking because you're not rotating the spine, okay? You can also, after that, hold on to the hips, have them rotate the spine, arch their back, and that's a good test for facet joint. You understand the difference, okay? The fourth thing is a positive straight leg raise test, but you've already kind of done it ahead of time and not told them. So while they're seated, the straight leg raise test, they're lying in bed and you lift up their leg and they say, ouch, right? So when they're seated, you look at the bottom of their foot, do a plantar reflex, something with their leg straight and their body at 90 degrees, and they're not hurting. And then you lay them down and, say, okay, how does this feel? And you lift their leg up 20 degrees and they're screaming about fire burning out of their toenails, right? And then if dorsiflexion makes a straight leg raise test worse, right? But if you plantar flex instead and they hurt even worse, now you really have made them catch a funny fish, okay? That's just not real, okay? So a positive straight leg raise test when a distracted test is negative is the 4th Waddell sign. And the 5th Waddell sign is non-neurologic pain. Now, the easiest thing to understand is one leg being paralyzed or a single leg having a stocking distribution sensory change. One whole leg is femoral, tibial, peroneal, obturator. It's pretty hard to get all those without a big tumor in your pelvis. And a stocking distribution is impossible unless this was like a World War I soldier standing in a trench for 12 hours and freezing their leg off, right? So either of those is not possible, okay? The more common way that you get a non-organic pain behavior is by the person displaying weakness when they really don't feel weakness. And the way that you'll document that typically is by ratchety giveaway. So if I pull on my arm and I'm giving full effort, but I've only got half my nerve cells, it'll just give out in a very smooth way. But if the person is trying to give effort halfway, it'll go, you can feel it go, okay? By the way, that's different from Parkinson's disease, where it's a very regular thing, and you can easily tell the difference. Now, of course, if somebody broke their ankle, they're not going to give full effort in their ankle, right? Because they hurt, and that's not faking. So later on, if they have Waddell signs, you can either do it in a lot of places and see how completely inconsistent with physiology this is, or if it's around the ankle and the foot, maybe later on you go, oh, by the way, did you ever break your neck or sprain your ankle? Like that kind of thing, right? The next big quiz on your examination is the neurologic finding, okay? And here, homework for you. I want you to think about the physical examination you'll do and just think about strength. Just think about your strength exam. On your strength exam, give me an example of what you're going to see that's an L5 radiculopathy and what you're going to see that's not an L5 radiculopathy, but instead a distal polyneuropathy. And what you're going to see that's neither an L5 radiculopathy nor a distal polyneuropathy, but a peroneal nerve lesion at the fibular head. On your strength examination, if you can't differentiate those three, you need to go back to the anatomy books and study. So seriously, pause. I really want you to do that. Okay, I'll come back to that. So your physical examination reproduces their pain, looks at pain behavior, looks at neurologic deficits. Okay, that's kind of your physical examination job. Let me come back to my slides just because they're fun, and I'll skip through that in as fast a way as I can, because you'll get the slides. Strength, reflex, sensation, compression signs. You know, the big theme here of being a good physiatrist instead of a simple primary care doctor is finding the exceptions to the rule. And with back pain, the exceptions to the rule are really, really common. There are so many things that mimic radiculopathy, okay? It's called the pseudo-radicular syndrome, according to Jeff Saul. And you need to be very good at never missing one of these. So my whole examination actually focuses on these because it's a no-brainer to then conclude that it's just a herniated disc with an L5 radiculopathy, or it's just a facet joint, okay? So think about this. I've got my poem. You may have heard it before. In the low back, you poke the troch, whip the hip, upset the facet, and smack the sacroiliac, because each of these can cause radiating pain. You look for polyneuropathy, for vascular disease, knee joint, ankle joint, peroneal neuropathy. In the neck, you want to take a good look at the shoulder joint. I got lots of people whose pain is in the neck down here, and it's really their AC joint, plus, mechanical neck pain, right? Carpal tunnel, ulnar nerve, other causes of upper limb pain. There are these diseases that are quite real, that are overplayed and overcalled in every physical therapy textbook in the world and every orthopedic textbook in the world. And if you look at the prevalence and you look at the history of false data and old data, you really kind of want to know what they are and then not diagnose them until you've been around for 10 years or something, right? One is thoracic outlet syndrome. Mayo Clinic's treated more cases of complications from thoracic outlet surgery than they've seen legitimate cases of the disorder. Yes, I've seen them. Yes, you'll see them. But usually my definition of thoracic outlet syndrome is their neck hurts and they got ulnar neuropathy, but the EMG wasn't very good. Okay. The other is piriformis syndrome. Back in the 1930s, a guy operated on hundreds of piriformis muscles, put them in the hospital for a month, and they got better. Duh, what happens to herniated discs, right? The literature has gone on and on and on. And yes, I've seen a couple cases in my lifetime. Somehow my local therapist seems to have seen 100 cases, right? You want to be really skeptical of those, okay? We talked about Waddell signs. You can just read through that. I'll shut up. And the mechanics. Now, this is the last part that I really want you to do some homework on, okay? For the second year fellows, everything till now should be a little bit of a review. And going forward, it's really time for you to become a mechanical expert. And there are a lot of different schools of thoughts. Okay, I'll call them religions, okay? A lot of different schools of thoughts about how to analyze the mechanics. And very best therapists use a little of this one, a little bit of that one. They were trained in a McKenzie physical therapy protocol, but they took on some osteopathic techniques. They met with a chiropractor, and it is how it is. So you need to get really competent at one. Now, the easiest one is McKenzie. Robin McKenzie passed away a couple of years ago, and he was very much into codifying things, and therefore the McKenzie exercises are A, everything your orthopedic surgeons know because they don't study this stuff, and B, really simple and codified and reproducible, and C, they work. They're really good. So I put a website up here for one slideshow that talks about McKenzie exercises. You folks can watch this video and get pretty competent at diagnosing and treating using the McKenzie model pretty easily. So I highly recommend it. However, it's not the only way. It's just the easiest way to do research, okay? There are a number of different schools of thought. And the other one I would ask you to at least watch a video on is an osteopathic examination. So I've got another link here, but there are many others. And this is where people are really using the artistic ability to feel stuff with their hands and measuring and moving. And for us boneheads, it looks like voodoo. Then you get really good training from somebody like my friend Miles Caldwell or our old mentor, Phil Greenman, one of the great osteopaths of the world. And you start going, oh my God, I'm really stupid. I'm not feeling what fantastically talented physical therapists can feel. So for you to understand how to do these, to get some skills, some rehab doctors, like my friend Miles or like Jen Doble, who talked to us last year, make a living doing much of this kind of work as a manual osteopath, chiropractor, physical therapist with rehab doctor skills. All of you will be referring off to expert therapists who do it all day long, who ought to be pretty good, but you need to understand what they're doing, whether they're getting the job done right. And often as you get older, you're going to be the most experienced clinician on the team. You'll often be teaching the therapists who are 10 years or 5 years out of school. So take some time to look at these videos and get kind of good at it. Okay. Then you get to play doctor. You know, you look at the old tests, you look at prior treatment. You do worry about the dangerous diseases. Will I order an MRI? Will I get a sedimentation rate? You need to understand that your job as a team leader is to tell the physical therapist, I don't want you to do any flexion exercises because she's got osteoporosis and you're going to cause a crack. Or he's got heart disease. We want him to get in shape, but you got to monitor his heart rate and his blood pressure while you're doing it, right? So you need to understand how medical diseases are going to interfere with your medicines, with your injections, with possible surgery, and advise your therapist on things that could be dangerous for this patient. Optimizing other medical diseases, thyroid not well covered, is a great way to help improve the overall care for this person. And you're a doctor after all, and most of you, by the way, have such great primary care background. Don't throw that away, okay? So at some point, you look at the whole picture medically and address everything, or get your friends to help address everything. And then you start teaching them, and I'm going to stop my sharing for a second. So here's how I'll talk to him at the end. Dave, thanks for letting me hear your story. Sorry I interrupted so much, but I needed, I'm the only one who can get confused, so I deserve to stop and make you tell me things in order that I need to hear. Appreciate that. And we did a good exam, and I think you learned something. Like when I pointed on that spot, that's where the pain came from, huh? Right. So let's walk through this in a rational way. I like to talk about it in terms of chapters, Dave. What could be dangerous? What do I think's really going on? How would I prove it? What are your choices about what to do about it? And then when we look at you, Dave, as a whole person, how do we put this all together? So what could be dangerous? Now, I always address this in everybody, okay? And almost always I blow it off. I say, I don't see anything dangerous here. If there was, and then I say, more pain is not a sign of more danger in your case. So a trip to the emergency room is probably a waste of time sitting in an uncomfortable plastic chair, okay? Progressive neurologic deficit, and I'll go into some detail, is an emergency. And if that should happen, you really should go to the emergency room. The reason why I bring it up is, first of all, so they recognize danger and act on it. But second of all, so that when they're anxious in the middle of the night and their back hurts and they don't know what to do and they're feeling helpless, they know that it's not dangerous and they can de-escalate their anxiety problem, right? What do I think is wrong? Well, I can't be really sure, but I think it's your sacroiliac joint, and I still think you do still have a little bit of nerve damage from that herniated disc. How could I prove it? Well, I, we could inject the sacroiliac joint, and we'll come back to that. It's a small risk, it's possible. I could do an EMG to prove that you still have nerve damage from the herniated disc, and we'll do that if you want me to at some point, but I don't think it's going to change your treatment choices, okay? So I talk about treatment options or diagnostic options. Things like cervical facets. I'll often say we could diagnose a cervical facet, but that little artery to your brain comes by, and it really ought to be worth it for you. We shouldn't just diagnose it for fun. And sometimes I'll joke and I'll say, well, if I really want to find out, I'll do an autopsy. Is that okay? And the patient will start laughing. I'll help them understand that the goal is not to diagnose. The goal is to make treatment choices that work, right? So what could be dangerous? What do I think is going on? How do I prove it? What do we do about it? Going back to my 5 fingers, and I always come back to the 5 fingers because they understand there's a theme. They understand that, like, this visit has an opening and a closing that makes sense to them, okay? It's like poetry or something like that, okay? Nothing surgical at all. Nobody ever operates on the sacroiliac joint. And unless you failed all of these and that pain in your foot was bad, there's no way people would operate on that herniated disc right now. That's off the list. Injections. You could try an epidural for that pain in your foot. Not really risky. You could try a sacroiliac joint injection, maybe 3 months of pain relief. Some people think it cures them, but usually it's just because they start moving naturally, and you might find a better way to do that. Those are good choices. They're in your shopping basket, Dave. Okay. Pills. Now, pills. And I put this up kind of as a joke. And I tell them, what you need to understand about medicines is they're not a complete waste of time, but no pill in any good research trial gets rid of more than 30% of chronic pain. And none of the pills make it go away. They just help you to feel better. So I'll talk to you about pills, and acetaminophen or paracetamol, non-steroidals, opioids are stupid, and there are a bunch of non-addicting chronic pain medicines that have in common that they take a few days or weeks to get working, and that they may have side effects, but if you have side effects, you usually see them right away. If you don't have side effects, you can stay on them for years. What do you think? Right then, here I'm talking about amitriptyline or gabapentin as the two most common drugs, right? But I kind of de-escalate and make sure they don't think I've got a pill that's going to get them out of jail. Okay. Therapy. And here, especially if they've had prior therapy, and some of my patients have been to 5 different PTs and 2 different chiropractors, I have this little ramble, and it says something like this. Therapy is really skill dependent and technique dependent. There's bad, good, and there's the guru, but that's a McKenzie therapist, Dave. And then there's an osteopathic therapist that could be bad or good or a guru. And there's a chiropractor, and there are lots of other schools. And in my experience, we can't tell which therapy is going to be best. They're all biased toward themselves, and we just can't tell. But what I do know is that a therapist's job is to teach you how to put themselves out of business, to teach you how to rescue yourself from an episode in the middle of the night, and to use whatever techniques they have to try to help get rid of the pain. But if it's not a lot better that you can tell at home within a month, that therapist doesn't have the skill. Okay. Even if they're the guru of McKenzie, you may have to switch to something else, or maybe therapy isn't going to help. So, Dave, as we go forward, and if I partner with the therapist in your local town or your favorite chiropractor, we're going to set goals and timeframes. And if they don't meet your goals, it's really rare for somebody to make a difference the second month. So this is all about consumerism and how I'll direct their therapy. Last one is do nothing. And they go, but I go, well, you don't like surgery? You didn't choose anything. When we do nothing, I'll say, that's when I get busy, because I'm a physical medicine and rehab doctor. The physical medicine is me doing physical stuff to try to cure you. We just talked about that. Rehab is the other part. And it turns out, Dave, that when you flip a switch and become a guy who's willing to rehab, the outcomes are twice as good as when I try to cure you for chronic pain patients, right? So, and this is a short talk for you on the computer because you'll get bored, but it kind of goes like this. Rehab's got 3 parts: getting in shape, ergonomics, and the psychology of pain. Every exercise study ever done shows that doing more exercise decreases back pain. Let's get you in shape. It doesn't mean hurt more. It means having some smart therapists teach you how to whip your body into shape. Ergonomics. Go home with the paper and pen and write down 40 or 50 things that you have trouble doing. Not 10, 40 or 50 things you have trouble with. And then, if we're lucky, we have an occupational therapist. Then I'll share it with your occupational therapist, or I'll have you do some common sense and sort it out. And Dave, the psychology of it is critical. As a swim coach, we used to say, practice makes, Dave says, permanent. Practice makes permanent. And I go, no. Practice makes permanent. The more you practice your pain, the more permanently you drill a hole in your brain that pays attention to the pain. So, Dave, we have to unpractice pain. And if I have a pain psychologist, we've got a lot of expertise. If I don't, Dave, you need to start thinking like this. Every time you think about your pain, I want you to think about hummingbirds or going fishing or your children or something happy. And every single time you think of your pain, you have to switch your brain to think of something happy. Now, doctors, this is really simple, but the idea of the patient battling for their own sanity here is really, really kind of critical. So I'll go through that whole list, and here I come back to my screen share again. Right? There's my chapters, right? And I'll shut up. Let's say, ask me questions. What do you want to do? I don't know. What do you think? And I'll say, I want to go fishing. That's what I think. Or I want to go to medical school. That's what I love to do. You're the only one who matters, Dave. What do you want to do? I won't give you any bad choices, Dave. What good choice do you want to take to start the ball rolling here, right? And at the end of all that, after Dave makes his decisions, the most critical job you have as their general contractor is to set goals and timeframes. If there's ever a theme in everything I've taught you in rehab, nothing's a goal unless it has a time frame, right? So physical therapy, you can see me in a month. If they haven't taught you self-management and decrease your pain by 50% in this case, they haven't met my goals. Amitriptyline, let's try amitriptyline. You take one every 2 weeks, or take one every night. And by 2 weeks from now, since you have a sleep problem, Dave, I'm hoping you'll see your sleep is better, but it'll take about 4 weeks to cut your pain by 30%. Stop the drug if you have side effects, but that's our goal. Give it 4 weeks. You want to try an SI joint injection? That's a great idea. Pay attention to how it feels while the anesthetic's working, because that's our diagnostic test. Don't waste your time. But it's going to take up to 2 weeks for the steroids to get kicking. When I see you 2 weeks from now, if it hasn't helped, we're not going to wait another week. It didn't work. Oh, you're really thinking about fusion. Well, let's talk about what your goals are there. The surgeon just said he could help you and he'd be willing to do a fusion. What were the risks? What are the benefits? Here's what I know about your particular fusion, Dave. Within a month or so, you'll start feeling better and be glad you had it. You've got a foot drop. Operating on your back does not make a nerve grow back. Nerves grow back as fast as hair. And if I could make it grow faster, I'd have a Nobel Prize. I don't. So surgery will not give you back that foot drop. Okay. You ask the surgeon after you get that fusion whether they'll let you lift and go back to your work shoveling cement. Because often after fusion, the surgeon won't let you do it because you'll ruin their surgery. Okay. My point here, doctors, is that when the patient chooses surgery, they need to understand the consequences of surgery. And sometimes it's the right thing to do, but there have to be goals and timeframes. And then that's the end of it all. So, can I emphasize so much that we're going to get into some serious medical technical stuff over the next couple of years and some techniques, but you will continually fall back on what I said today. And if you don't, you're missing the boat, because this is where it all is. Me, I'm going to fall back into that lake down there and go swim across the bay. And I hope that even though it's always warm and always sunny in Africa, I hope you're having a great time. Take care.